Okay, over to you, Tom.
Thank you very much, Ria. Right, I'll straight away share my screen. And today I'm going to talk about how to overcome today's lack of NHS process documentation to support improvement. And the work that I've put together here is based predominantly on Duran's and Deming's teaching, and it also meets the requirements of clause 7.5 of the new British and international standard for quality management in healthcare. And this clause is the one that talks about documentation. I'm a research fellow at the University of Birmingham in the Institute of Applied Health Research, and I've been there as an honorary research fellow for the last 7 years. And during that 7 years, I've been studying and researching process management and quality management and patient safety in the NHS, mainly via the Q community. There's some information there about, I should add that you'll be able to get access to all of these pages when I've finished. So a lot of the detail really is for you to read at a later time. Otherwise, I just won't have time to go through all of the things that I want to talk about. So this is really, as Matthew describes it, as a sort of a resource really for references that you can use afterwards, but you need to, of course, listen to what I'm saying to know where all the different bits and pieces fit in. So I'm going to talk about why you ought to document your processes, understanding a little bit about quality and quality management, the two concepts of quality management systems that we're faced with. It's the same system, but there's different detail on both. The definition of a process. Defining your processes is one of the most difficult things, and confusing process with procedure is a common mistake. Process is going to be gone into in quite a lot of detail in this little chat. Then I'm going to talk about what a process flowchart looks like, because how you produce your flowchart, your process flowchart, means a lot to the people that are going to be using that flowchart in the future. It's got to be clear and simple. And then I'll say what a process flowchart really should look like, instead of how we're told it should look like. And then how to do it, how to create your own flowchart, making a start on process flowcharting, and finally producing your own flowchart documentation. So I'll get straight on into that. So first of all, why document your processes in the first place? Well, there's lots of really good reasons. And one of them is that it's a necessary first step towards implementing a quality management system. And there's a new British standard and international standard. And this standard was produced in conjunction with the WHO, the World Health Organization. So it's an international standard that's been sort of put together with people that are working with the World Health Organization. So although it's been produced as a British standard, it is really an international standard, and it's been produced from an international group of people. And the clause that talks about documentation is clause 7.5. Okay, it facilitates process management. Now, process management is the sort of stepping stone to quality management, and it's a key requirement of a quality management system. And it facilitates innovation. People don't realize that, which is another key object of a quality management system. It enables process standardization and best practice, and there's lots of reasons why you want to have more standardization, and one of them is to facilitate IT and AI. If everybody is doing things differently, then it's impossible for computer programmers to understand what the customer really wants from their applications. A key element of process documentation is that you can do desktop reviews. Instead of having to go and watch people doing the work. You can do a desktop review where you can identify areas for improvement, health and safety issues, patient safety, definitely patient safety. And I've done a couple of links here that will take you into more documentation and more detail on patient management systems and other links for more detail. Human factors, ergonomics, sustainability, and there are lots more reasons why you should do desktop reviews of your process documentation. A really important one is training. If everybody's trained on the same process, it makes it a lot easier that when you've got issues within your process, everyone understands what the baseline was. And there's going to be a little bit more on that. Really important is that you can establish a learning health system. Quite a lot of change in the NHS has got to be substantiated by the science. Well, there's not much science around quality management in healthcare because they haven't ever done it before. So the science isn't there at the moment, but no doubt it will come. Let's have a little look at the science. And there's a from our own Q community, there's a paper here on the 4 icons of patient safety. And what I wanted to look at is the first diagram, which talks about simple, complicated, complex, and chaotic. That's going to come in quite a few times in this little talk, and it's really important when it comes to patient safety, because it's when you get into this area that patient safety becomes a real big issue. But it's not the only time that patient safety is an issue. There's a load of there's 4 different illustrations here, and what I really like is this one, where we talk about work as imagined, work as prescribed, work as done, work as disclosed. They're all different, but what really is important is work as done. So I'm going to be concentrating on work as done, because there's no point in producing a process map if it's not a process map that everybody follows. The idea of producing a process map is to get some standardization in your processes so that you can do improvement. If everybody's doing it differently, then improvement becomes extremely difficult. There's another bit of science here, the clinical gaze, and there's a couple of important paragraphs here. One is that one of the issues with patient safety is visibility. Sorry, I lost my word then. Visibility. Because everybody's doing it different, and no one really wants to admit how they do things, there's this lack of visibility. And if people can't see from the outside what's going on, then there's no way that they can help make any improvements or suggest any improvements on how that process should operate. I'm just going to have a little look at another version of the first image, where we talk about, again, clear, complicated, complex, and chaotic. And there's some little illustrations here that illustrate a picture describing that topic. So if it's clear, then it's going to be like an IKEA do-it-yourself putting together a cupboard. And to do that, you need a bit of skill. And here it's a little bit more complicated, and you need some expertise. And when it gets into complex, you need a network, and that's really important. Network. It comes into the aviation industry. Have done a lot of work on patient safety, and one thing that they have is a CRM, a cockpit resource management, and it's a network of people and resources in a difficult situation that you can call on, and it's not an individual, it's not just one person, it's a network. And if you get into chaotic, then we're in trouble. So what's really important when you're doing this process mapping and trying to understand processes is keeping it simple. So this is an American term, KISS, for keeping it simple. I don't use the last word. Okay. That's why you should be documenting your processes. So now I'm just going to have a quick look at understanding quality. What do we mean when we talk about quality, and what are we producing that has this value called quality? Well, when you're talking about quality, especially quality management, you've got three areas to look at. And this terminology might be a little bit difficult for you, but it's the terminology that's used internationally through the quality management fraternity. So the first one is your deliverables. And I'm going to go through each of these in turn to talk about what they are. Then there's the realization system. And then there's really the people and the culture of the people, the sort of management system culture. Talking of management systems, quality management systems, here, when you talk about managers in the NHS, I know it's a bit off-putting because it's all about people management. But quality management isn't about people management, it's about people managing quality. And there's a subtle difference there. Everybody in the organization is responsible for quality management. Whereas people management, then the managers are responsible. So what are your deliverables? Your deliverables are what you actually deliver to the patient or for the patient. So starting off, the diagnosis is a deliverable. But we usually consider that the services that we offer to our customers, to our patients. So your deliverables are the services that you offer, but within those services, there's lots of smaller deliverables, like X-ray plates or as I said, diagnosis. One of them, ones that's really important to me and to the NHS is the summary, the discharge summary. That's another deliverable. The deliverables are defined by the fundamental standards, and they're all there for you to see. You're probably very familiar with them already. There's the NHS service standards and service specifications. I'm not going to spend much time looking at these because you all know that they're there and you can get access to them. But these are the things that define the services you offer. NICE is really important, I think, and I like the Get It Right First Time reports that are starting to come out and have been coming out for a while. So all of those documents define your deliverables, and it really is up to you and your trust to say which of these documents you're going to sort of put your trust in, because there are so many. There was a talk I gave previously where someone was looking at the standards for one of their services, and they found 150 different documents that defined that standard. Well, you can't really design a standard to meet all 150 of those requirements. So you've got to pick and choose a little bit and say what it is that your service is meeting as a standard. So that's your deliverables. And that's one element of quality management. You've got to manage the quality of your deliverables. The next one was the realization system. And the realization system is made up of people, departments, work teams, patient pathways, your processes, your tasks, your procedures, your culture, your management system, and there's quite a few other things. And I've done a couple of links here where we can have a look at the sorts of things that might influence how people respond to the work that they've got to do. Some of the issues that might prevent them from working at their best. And I've also done a bit on culture as well. One of my favorite writers is Sonia Sparkles. And she produces these little things about little illustrations of. I know Matthew likes all of these pretty pictures. I'm not very good at them, but that's a good one that illustrates your culture. And patient pathways is what your realization system is there. And this is just an example. And I'm going to come back to this patient pathway. Now, this isn't a process and it's not a procedure. It's a patient pathway. It's a workflow. That's another important difference that you've got to understand when you come to process mapping. And how about some upside down management? This is an organization that you might have heard of, Timpson's, and they have done some upside down management where the people that are customer facing have got a lot of responsibility for how they undertake that role. So that's a good idea, and that's part of how a quality management system works. And I just wanted to say here the difference between how you undertake quality improvement and which tools that you use are different when you're looking at improvements to your deliverables as against your realization system. So you need different techniques to undertake improvement in those two different elements of quality management. And the QI approach in the NHS doesn't really differentiate between those two different types of improvement. Okay, that was a bit about understanding what quality is all about, the different areas. So let's have a look at what people understand as a quality management system. So here I'm going to look at two different concepts of quality management that are the same system, but that there's different detail. And I use my friend ChatGPT to put together these two different concepts. The first one is a description of the system, and it talks about planning and execution, and it covers some of the key concepts of quality management. And it talks about the process approach, which I'll go into in a bit more detail, and it covers the foundations of a quality management system. So fair enough, that's okay. There's something missing though. This is another concept where instead of just having the two elements at the beginning, they've got the plan and the execute, but they've also got the manage. And these are several key concepts, not just a few key concepts. And it covers a lot of the same topics, but at the end, it talks about providing a framework for quality management systems instead of just a concept. So you've actually got that framework there. And what's the difference between a framework and a management system? Well, you'll have to decide yourself. Some widely used models of quality management systems that are used in the NHS, and you've got to sort of ask yourself what's missing from these illustrations. So here's one that Scotland used. They used Duran's trilogy, but they've reworded it slightly. Instead of planning for quality, instead of quality planning, they've got planning for quality, which is slightly different. And instead of quality management, they've got maintaining quality. So they've muddled things about. But the one thing that's missing from this is the elephant in the room, which I'll come to in a minute. Wales have got another version, which does include a bit more detail, a bit more, well, I don't know whether it includes a bit more detail, but it's different, isn't it? Another one is the East London Trust, and they often talk about their quality management system, and they have used Duran's trilogy, but again, there's something missing. And NHS England, well, theirs is a little bit bland. I don't know whether that's their actual one, but it's the only one I could find looking through the literature that they produce. So here we have another version, which is the one that quality management, the British standard for quality management uses. And the difference between this and the other ones is that it does have a management system. All the others didn't have a management system. They just had a vision. This has a specific management system, and they use the Plan, Do, Study, Act acronym to support their management system. So that's what's missing. And process management is an integral part of quality management. Also, by the way, an integral part of patient safety management. And in my view, I think that the quality management system that the NHS end up adopting should include safety management. You can have a joint system, quality and safety management system. The two systems, the one that is used by British industry for quality management and the one that's used by the aviation industry for safety management, look very similar when you look at them. And they've got the basic principles behind those two systems. And there's no reason why the NHS can't combine the two, which will give everybody a greater understanding of what's going on. Instead of having two systems to follow, they'll just have the one. Okay, so that's a quality management system. So as I've said, the essence of a quality management system is process management. Whether you agree with me or not, I don't know. So what you've got to do is really understand process. So a process is fairly simple. It's a series or set of activities that interact to produce a result. It's a set of activities, a set of tasks, a set of procedures. It doesn't matter what you call them. There's a whole set of things that sequentially go together to deliver something. And there's quite a few different definitions here that you can use and different terminology. In addition to that, there's well, I'm going to come on to that in a second. Yeah, I'm going ahead of myself. I'm going to talk about a process approach. But first of all, we want to look at the difference between process, policy and procedure. And I've got a little diagram here, which I did a long time ago in 2003, where it puts the three elements in perspective. You end up with a detailed task. And what's important here is that the detailed tasks, the operators will have been taught that in training. These are your medical procedures that you undertake on the patient. And you really don't need to cover too much detail on what they consist of in your process diagrams, your process illustrations, your flowcharts, because people have already been taught that. They should already know it. It's what their job is. So we've got the vision at the top. We've got goals for each functional area. Within each functional area, we've got work teams, we've got processes, we've got procedures, and we've got detailed tasks. And that's really a hierarchical diagram to show the difference between your work standard, your process, and your detailed task. I don't know if that was clear enough. But if we'll move on now to just have a look at the process, the elements of a single process. And you see here, the activities of your process are only part of the process. The things that affect the quality of your output are the quality of your inputs and the quality of the people that provide your inputs. The outputs are going to be, the quality of your outputs are going to be very much defined by the quality of your processes and the activities within your processes. So that's a diagram that ISO 9000 use to illustrate the elements of a process, and it's quite important that's understood. I'll go back to this diagram that we saw at the beginning, a different version of it, where you've got complex, complicated, chaotic, simple. Now these are, some people apply these to processes and say, oh, we've got very complicated processes. Well, you haven't. You've got very complicated situations where those processes are enacted, and decisions have to be made as to which process you undertake at that time. So you mustn't mix these different complexities up with the actual processes that you're undertaking. And one of the reasons systems do become complicated or complex or even chaotic is because of the lack of visibility as to what processes you're supposed to be undertaking and how you implement that process. So that diagram is really important to understand. And I've got to go back to that other image where we looked at it. I'm going on. This is so important when it comes to patient safety management. And people seem to think that this has got something to do with your processes and where your processes become problematic. Well, the processes don't. It's the situation and how you apply those processes. The processes should be second nature to you and really understood through practice. That's where your skill develops. And patient safety and risk come into managing that situation. And that situation can be managed a lot better if your processes are really better understood. So Toyota, who have been famous for implementing quality management, their view is that your consequences and your process outcomes are less important to the nature of the people's actions at the process. That's understanding the situation. Your cabin resource management, how you use your resources in a difficult situation. The NHS and quite a lot of other organisations put a lot of emphasis on measuring process outcomes and suffering the consequences and trying to minimize the consequences, the bad consequences. But Toyota say that the more effort needs to be placed on the process and the people's actions at the process. And that's what the quality management system does. It works in this area, and it's the people's actions to maintain the quality, not measuring the quality at the outcome. And this is called a process approach, and it's a way of thinking. The process approach is the same as systems thinking, where you've got a whole series of processes in a system, but one process, the output of one process is the input of the next process. So you've really got to be sure that each process delivers the right quality of output in order to have the right quality of deliverable for the patient. And that's called a process approach or systems thinking. You can look up systems thinking and see what it says. And this is the process approach. Systems thinking and the process approach are very similar. And there's a little bit more there about the diagram that I showed earlier. And you can get some further reading here on the process approach and really important in the development of the new standard, the one that I've talked about already, that the World Health Organization developed was their High Fives project. And you'd need to have a read of that, where they designed some standard work, some standard processes, and they tested it across several countries. And the UK was a member of that project, but I think they dropped out of it before the finish. So that's a little bit about understanding what a process is, and that's really important, differentiating between system, process, and procedure. So what does a flow chart look like? A process flow chart. This is all about documenting your processes. So there's loads of examples of what a process flow chart looks like associated with the NHS. And I'm not going to go through all of these, but if you Google it, this is what you get, all of these pretty little diagrams. And don't forget that a process is a set of sequential activities. And it's difficult looking at some of these to identify a single flow, a set of sequential activities. But this is what we're told is process mapping. And there's a nice one. Process mapping in quality improvement. Yeah, process mapping. I like this one. This is a good one. This is what Wales have, and I quite like this diagram, just let me get rid of that. And this is making a cup of tea. Now, I'm sure we all know how to make a cup of tea, and there are 17 different tasks in this detailed map for making a cup of tea. And does that look like a sequential series of tasks? It doesn't really look like that to me. So there's lots of confusion as to what a process map should look like. And there's more. Value stream mapping isn't the same as process mapping, although it's mapping a system, not mapping a process. And post-it note mapping, if you're trying to design a process and it's this complicated, you'll never get there. You've got to keep your process design simple. So now here's the thing. I've shown you all of those examples of how to map a process. Well, I think they're all how not to map a process or creating a process chart in the NHS. That's my view. Fortunately, no one agrees with me. I mean, unfortunately, no one agrees with me. So what should a process flowchart really look like? What should it look like? Remember, keep it simple. So this is what a process map should look like. You've got a series of sequential tasks, as the definition told us in the first place. To that set of tasks, you can add some procedures, some descriptions of the procedures, not necessarily the complete procedure, because the procedure might be quite complicated, particularly if the procedure is to remove someone's kidneys. I don't know if that is a procedure in the NHS. I'm sure it might be. So I've got some examples here of what a process map should look like. And some of them aren't very good. Here's a fairly simple one of the evaluation process where you go through a sequence of tasks. That's what a process is, a sequence of tasks. Ward round, this is taken from the Royal College of Physicians document. There's more than one process involved in this. This should be subdivided into 2 or 3 different processes, but it's an illustration that I've got. And there's blood sampling. This is one that I did in a long time ago to help a student, and we've got an overview of taking a blood sample, and each of these overviews can be split into smaller processes. And this was someone that from Great Ormond Street Hospital did it for her master's degree. She was working on compliance. So that's an example of a process map. I've got one here I did. This is a whole series of processes for during the COVID pandemic for sample testing. And each of these has got a process associated with it. And it's a simple process there. It's not drawn up. These are just examples. District Council. I did some work with the District Council and identified all of their processes in each of the different departments. And the NHS will have, over the whole of a trust, will have a diagram much bigger than this, but you keep it into a more sensible set, just a department or a group of people. I've got a few more here. Discharge summaries. This is one that I'm working on at the moment, and discharge summaries. And what comes into this is the board round and the ward round. And there's a few more here that I haven't got time for, but here's one. The one I showed you earlier for making a cup of tea. This is a process map for making a cup of tea. We had, was it 17 different tasks in the other one? Well, there's only really a couple of tasks. You put the tea bag in the cup and put some hot water on it. And then you wait a few minutes and take the tea bag out and put some milk and sugar in. So that's the difference between how people perceive a process should be mapped and how a process really should be mapped. So I hope that's given you an idea of what process mapping should look like. I'll just pause here to see if there's any questions. Maria, I don't know if you can have a quick look and see if there are any questions that we could ask.
Yes, thank you, Tom. There is. So I think the first one came from Paul Violence. I hope I'm saying that correctly. I don't know if you would like to ask it yourself, Paul.
No, fine. You carry on.
Okay. Can you see it, Tom? I'll just read it out loud. Ought the conversation not to be extended across the NHS and ASC local authorities, not just the clinical sense, but the overall flow across the patient journey as a whole, rather than just the NHS boundary. Thoughts, anyone?
Yeah, I don't know if I heard it correctly, but yes, processes right across the whole work activity of the organisation should be treated in the same way. Did that answer the question? I don't know whether I heard it properly.
Sorry, I will jump in there. It's more not the organisational boundary, and yes, I agree. All processes should be the same across all health trusts, but there are also other things, that perhaps less clinical things, that need the process extending across the patient journey as a whole, not just the clinical context part. And I think that's where historically it gets complex, and also the propensity to limit a process to an individual care boundary. So as if to almost by default set up the blame scenario. Well, we've done our bit, it's somebody else's problem now. Does that make sense?
Yeah. I think all activities that require it should be processed. Should have process documentation. Yes, and the way that those processes link in together can be shown in the process diagrams. So it's not just clinical activities that need to be processed. The clinical activities are the smallest number of activities maybe in a trust. A lot of the administrative activities are just as important. I don't know if that answered your question.
Yeah, it does. Thanks very much.
Yeah. Definitely, the whole set of activities should be, in my view, should be treated the same.
Yeah.
Okay.
Great.
Shall I move on?
Paul. I think there was also a couple more questions, so maybe we'll take a couple more. Matthew, you had one, I see, about the complex emergent domain requires a different approach rather than a conventional quality management system. Do you want to make any comments, questions?
Yeah, well, I have a recollection that me and Tom didn't quite see eye to eye on this, but I'm not quite sure whether quality management systems are focused on, the simple domain and the complicated domain, but actually it's something a little bit different when you get into the complex domain, where it's much more about probes and experiments. And I'm just not quite sure if that's a whole different approach. But I never fully got my head around Dave Snowden's Cynefin stuff yet. So I don't know if you have any quick thoughts on that, Tom.
Yeah. The processes, some of the procedures in healthcare can be more complicated than the processes. The processes aren't complicated, but how the situation becomes complex, not the process. Selecting the right process can become complex. The processes should all be as simple as possible, but when and how you apply them can be complex. I really can't go into that anymore, or we'd run out of time. Did that answer your question a little bit?
A bit. I think it's maybe too big to get into.
Yeah.
But
Yeah.
yeah, let's move on to, were there one or two more, Maria? I can't remember. I see Jem had a long one. I'm
Yeah,
not sure if there were others as well.
there was a really simple, direct one from Faye on why we should be taking out the detail when the variation can be found. I don't know if you want to add anything, Faye.
Oh yeah, sorry. I do process mapping all the time, but perhaps Tom, it's not what you would class as process mapping then. So we do try to keep things as high level as possible, but often when you do map out a process, there is lots of variation in it. And so when I was looking at your examples, they were really simplistic. But my question, I guess, was really about why we should try to take that detail out, because when you find that variation, that's where a lot of improvements can be made, or a lot of the variation can be reduced.
Yeah. Let me just go back to this again. Which one shall I look at? Maybe a ward round. Although that looks fairly simplistic, you can have a lot of documentation behind this. You can do links to all sorts of things where there's stuff, where there's relevant stuff that you need to talk about. But the basic process is simplifying that complete process is the aim. If the processes aren't understood, then it does become, you can get into one of these complex situations. But in the background, you do need a lot more information than is just shown in the simple process map. So there's all sorts of ways that you can link in to provide more information in the background. If you try and put too much information into the illustration of the process, people lose track of the process and spend too much time on the individual aspects of the process. So
yeah, I guess I'm just thinking about an example that I'm literally doing at the moment. So I've just come off a process mapping meeting about 2 minutes before this, and we're trying to map across about 9 different tumor sites what our cancer pathways look like, and what processes are followed throughout that. And what we're trying to do is to look at the differences between each of those and what experience the patient would have throughout, who's involved and all of that kind of stuff. And to do that, I guess we need to pull out the differences. And so if you map it too high level, then it doesn't give you it doesn't give us what we need to be able to try to identify the variation and to try to reduce it.
Yeah, that's the whole aim of this, is to reduce variation, because you can't really have improvements of each aspect, each variation. To improve, you've all got to be doing the same thing so that you can all improve together, rather than have 10 different variations that all improve slightly. So you do have to arrive at some sort of works process standardization, but it's deciding where you. I mean, this example that I've got here isn't really a process, it's several processes, and it's splitting things down into their individual processes so that you can simplify those processes and then tie the processes together to create a system. And sometimes people try and improve a system rather than trying to understand the separate processes within that system and improving those processes both separately and then how they fit in within the system. So
yeah, I can see that. I guess sorry, I don't want to take over the whole conversation. I was just thinking.
I chip in quickly. Sorry, it's just because Tom and I have had many long debates on this topic over the past, and I've been trying to learn from coming at it from a quality improvement team's perspective, what you're trying to get at, Tom, and what the difference is. And I think I've just about got my head around it. So I think the key bit is, and I assume, Faye, you coming at it from a kind of a quality improvement style approach, service improvement approach, we typically are working with processes where we're dealing with problems, and we're not trying to define the process or the procedures. We're trying to work out why it's not working. And I think when you're doing that, it is necessary to sometimes document multiple bits of process together and to go to varying levels of detail, because we're in the process of trying to understand why things aren't working. I think what, Tom, you're talking about is how do you define what should have been happening in the first place? And I would say they are two different tasks. They look similar, but they are indeed very different. One is trying to define what the standard should be and to define that at different levels of detail in order to allow the management and of that system to be documented effectively and managed effectively. But when it comes to, if you let's say everything was documented and done in the way that you're describing, Tom, but it's not working, it's clear, for example, we're not seeing the right outcomes as a result of that, and whatever we've designed isn't perfect, we then need to investigate why. And that's where typically a QI team style approach would be coming at it, trying to drive into the detail and understand what are the issues and what are the things that we should be doing differently, what should be happening. And this is something, Tom, you've really helped me to understand, is the outputs of any improvement work should be, we either should be going back to those standards, and if they don't exist, defining them in an appropriate format, and if they do exist, then revising them. So every improvement should work with an either development or a revision of documented standards, processes, tasks, protocols, whatever it might be. But that's the difference for me, is what we're talking about here is how do you define them? So you've got a library of documents that describe what good looks like for your organization. How do you reliably deliver high quality care, and who does what, and what's that level of detail? I think I've really struggled to get my head around this because I've been typically trying to fix the plane in the air. It's the best kind of analogy I'll give to it, where we don't have a lot of this stuff documented. So we're often trying to document it for the first time whilst also trying to diagnose the issues. So that's often why I think Tom and I have been coming at the same thing from very different angles. But if that helps a little bit, just to explain, what we are doing is very similar, but they are different activities for a different purpose. I'll shut up now. Let you carry on, Tom.
Thanks, Tom. Yeah. So, okay. So the stuff I'm talking about here, documenting your processes like this, in my view, it's going to take the NHS many, many years to get to the situation where they've got well-defined, well-documented processes. You're so far away from being anywhere near it. You've got a lot of work to do. So I understand why it's difficult for people to understand really the difference between what you're doing now and what I'm suggesting that you should do in terms of quality management. It's going to be a difficult journey because with the degree of variation that there is not only across the NHS but within one trust and one work team, you know, the night shift do it completely different to the day shift. Then there is a lot of work to be done, and really you'll never really start to improve until you've standardized first of all your processes and then your procedures. That's my view. Anyway, how do you actually start doing this? Well, first of all, how do you do it, and then how do you make a start at doing it? Well, the first thing is to make a simple task, a simple list of all of the processes within your little work group, and you can use a template to do that, where first of all you list the tasks. So one group might have, and these are only the key tasks, not the putting the kettle on task, but the key tasks that you do that affect the outcomes of the patient's treatment, and all of those tasks won't be patient-facing tasks. They might be filling in reports and that sort of thing. But nevertheless, they're processes. So first of all, you list all of your different processes, and that's quite a difficult task. And you can use the same sort of template where you can use it to list the different processes or list the different tasks within a process. That's where you start, and you can do that not by having a meeting, but you can do it during the morning team brief. Just say to the team, right, what are the main processes that we undertake during our normal working day? So that's the first thing, is to make that list, because at the moment that list doesn't really exist, because I've tried to find people that can give me that list. Once you're happy with your list, you can start adding people that are involved with that process or that task, and what sort of processes or procedures that you have. Remember, this might be a list of tasks within a process, or it might be just a list of actual processes that you've identified in that work team. But you know, you can easily make a template for putting these sorts of things together. But you've got to remember that you're using a process approach. So each process has got inputs from a previous process, and it's got outputs for a following process. And system thinking, you've got to have pretty clear understanding of what system thinking is all about. It's lining all these processes up to give you a system rather than an individual process. So there's a whole range of processes that you can identify, and for Jeremy Hunt and his budget speech about improving the NHS, he talked about IT applications, digitization, AI, productivity, efficiency, costs. All those sorts of things can be will be influenced by your processes, and process improvement is very, very difficult until you've actually identified your processes. So that's the starting point, is to identify all of your processes. And I haven't got much time left, but in only 3 minutes. But I'll quickly go on to making a start on a new process. Remember that you're looking at work as done, not SOPs or anything else. You're just looking at the work that people are actually doing. And if you remember the workflow diagram that we looked at earlier, we'll quickly have a look at how you can turn that into a series of processes. The first step is to create your workflow diagram. So these are the separate processes within that workflow. But they at the moment, we just look at them as processes. They might be several processes within each one of those boxes. And then you go from that diagram to a more detailed diagram where you've actually identified some processes. And I use a lot of this hyperlinking for my diagrams, and it makes things a lot easier. When you've got several processes there, you can link them in. And for surgery, this is where NatSip will come in, and I've got a process map of version 1 of NatSip. It's gone to version 2 now, where each of these can be identified, and some of these boxes will actually be processes within their own right. This isn't really a process map. It's several processes. So you end up with a whole series of processes within each of these activities. And then once you've identified those processes, you can have a look at identifying the tasks within those processes. One that I'm working on at the moment is discharge summaries, but that's a right minefield, and it comes back to the ward round. So within this, you've got to the ward round has got to be good for your discharge summary to be produced. So that's the next stage, and then the final stage is producing the basic flowcharts for the individual processes that you've identified from each of those elements of the patient flow. That was very quick in the last couple of minutes, but do you? I hope you're getting an understanding of how the documentation element of quality management it comes together at the end of the day. And it is a very big task, but once you've got this organized and you understand it, the next thing that you do to improve is to reduce the number of tasks within each process by applying technology and AI and all sorts of different things that can take the people pressure off that task by using technology. And but you're never going to be able to do that until you've adopted this process approach and systems thinking, where you identify your system, and then within that system you identify the processes, and within each of those processes you identify the inputs and outputs and the tasks or procedures that are required to achieve those inputs and outputs, making sure that those outputs are suitable for the following tasks, the following process inputs. So this is systems thinking. And without all of this, you're not really able to do proper systems thinking or glean anything from your systems thinking. And all of this, once you've got it all going, it leads you into real proper process management. And those of you that have been on any of my webinars before and have been able to keep up with everything I've said will have seen this before. And this really is a learning health system, and it's also a quality management system, and it's a process management system, and it's an improvement system. It's all sorts of things, but this is what quality management is really all about, and this is what your end aim is. But in order to get there, there's a real lot of work to be done in the NHS. So really, we've run out of time. What I will do is go through the questions that have been put into the chat, and I will provide a written answer to everybody that's been on the call with my view on the answers to the questions that have been put there. You can get onto these slides by putting that URL into your browser, and you can email me anytime you want with a question related to this webinar, and really that's it. Thank you very much for joining in. I don't know whether we've got time to go live in any way, Marie.
Thank you, Tom. Thanks everyone for coming along. Yeah, I mean, I'm sure that if anyone has any burning questions, you're very welcome to stick around for a bit. But other than that, I do know that people have to run on to other meetings, etc. But do join the Process Visualization SIG Special Interest Group on the Q community, because Tom will post some updates in there following on from this webinar. And if there's any other webinars coming up, there's nothing in the plan, but there was some ideas I saw in the chat, and I know Tom can talk about this for a long time, so has a lot of stuff to say about it, of course. So there might be some follow-up webinars. Other than that, I think that's it. Anything else I forgot to say? Matthew, Tom?
Jem's got his hand up, is he?
It was just a quick one, just to suggest maybe as a follow-up, something around putting a bit of definition around what are the different type of documents maybe a healthcare organisation might need to have, and what should be held in each document. So I think you've quite helpfully described the difference between processes, procedures, task instructions. There's also guidelines, there's clinical pathways, there's policy documents, there's service specifications. All of these have various levels of detail describing who should be doing what and how things should be working. But in my experience, they tend to be hugely variable with different documents. So I've seen procedural tasks detailed within policy documents. I've seen details within clinical pathways which look like procedures, but they might not be procedures. But it's really hard to know what we should be aiming for. And I wonder whether that might be a helpful topic, because certainly I know we've had many conversations, Tom, over the years about how best to document and really to do this well for a document management system and for a quality management system. And I do think that's still really confusing, and that would be helpful potentially.
Yeah. And getting access to the different documents is difficult as well. I like using hyperlinks where you can get a picture and you can hyperlink into any document that you want, but that's quite difficult to set up. Although it's not that difficult. It can't be if I can do it.
Well, it's a bit harder in the NHS because we have all sorts of information management challenges that we have to navigate. So it's all doable, but it's quite complicated.
Yeah, one of the problems with the NHS, they've made everything too complicated. It needs to be simplified so much, and it's difficult to simplify it when everything's in a sort of a different wallet somewhere and tie in different. Like I said, that one investigation identified 150 different documents describing the same process. You know, that's just impossible to manage or even understand, or you know, which one do you take notice of, because they're all quite formal documents.
Absolutely.
It is a real difficult situation, but it's never going to be resolved until people start thinking about it and resolving it. And,
100% agree. I mean, we're in the middle of looking at now procuring document management systems for precisely that reason, because it's really hard to try and find simple ways to make this work for teams, especially those who aren't actually on site. So we have to, all our clinicians, we're community based, so we work in people's homes. We can't just have a massive document library that people carry around with them. It's not practical, so we need to look at electronic solutions. So yeah, absolutely, it's a challenge.
It is, yeah. Okay, I don't know if anyone else has got a question or a comment. No.
Okay, well, till next time, everyone. Nice to see you, and yeah, have a wonderful afternoon.